Hello students, I am Dr. Onimezde. In continuation of the last lecture video of module 6 BPA 202 paper, I am again starting the peptic ulcer topic. I have already mentioned that peptic ulcer is the disease condition where mucosal surface of the gastric cavity or duodenal cavity is destroyed. In the last video, I have concluded the discussion by the difference between duodenal and gastric ulceration. We have already known that duodenal ulceration is more common than gastric ulceration because it occurs just below the pyloric sphincter at the first part of the duodenum. The next part, risk factors. The main factors which are responsible for peptic ulceration are: number one, bacterial infection, Helicobacter pylori. Helicobacter pylori, apart from the Helicobacter pylori, there are several factors are there. Due to consumption of non-steroidal anti-inflammatory drugs, peptic ulcer can occur. Number three, steroid therapy. Number four, smoking, excess alcohol intake. Genetic factors are also there. And another important factor that is also genetic or internal factor, Zollinger-Ellison syndrome. I will later describe what is Zollinger-Ellison syndrome and what are the causes behind this. Another important interesting factor is the persons carrying blood group O have more prone to peptic ulceration. This condition or this factor is not elaborately described in any type of research journal, but epidemiological study has confirmed this fact. And last, hyperparathyroidism. H. pylori or Helicobacter pylori, which is the main cause of peptic ulceration. This is a urease producing gram-negative bacilli. What is gram-negative bacilli? I think you have known that. In the developing countries, the infection occurs through food. Infection increases with age. What is the role of Helicobacter pylori in peptic ulceration? Generally, the infection area is mucosal surface of the stomach. After infection, the inflammatory responses is produced at the surface of mucosal layer. After infection, it can cause gastritis, which is a chronic inflammatory response. Due to increased gastritis related problem, indirectly gastric secretion is enhanced. Gastrin is an important factor for secretion of HCl, which can cause continuous secretion of HCl without any food intake. Later in stage, gastric metaplasia is developed. Ultimately, damage of the mucosal layer and ulceration is developed. This condition, the consequences or connection between H. pylori and gastritis or peptic ulceration is very important for your syllabus. One question can arise from here. What is the role of H. pylori in gastric ulceration? And this is the answer. I repeat, due to infection of H. pylori at the gastric mucosal layer, inflammatory response is developed, which is called gastritis. Due to gastritis, increased gastric secretion occur later in stage, which can cause gastric metaplasia. I think you know the term metaplasia. Metaplasia is the formation of abrupt ulceration or tumor-like condition in any area, damage to the mucosa, and ultimately ulceration. Due to ulceration, there is an increased risk of gastric adenocarcinoma. Therefore, gastritis, gastric ulceration can be converted into cancer, gastric cancer. And what is the meaning of the term adenocarcinoma? Carcinoma means development of cancer in epithelial cells. Adeno means the area where mucosal cells are present. Here, the mucosal cell cancer of the gastric surface is termed as adenocarcinoma. Therefore, H. pylori has a role in development of both gastric ulceration and adenocarcinoma. Symptoms. Due to gastric ulceration, the minimum symptom, the primary symptom which is developed, that is nausea or vomiting tendency, and anorexia, which is weight loss. Anorexia means weight loss. After that, upper abdominal pain is developed, continuous weight loss. At the cardiac end of the gastric surface, a continuous pain is developed. This is the reason behind heartburn. After primary symptoms, gastrointestinal hemorrhage can be developed due to continuous bleeding of the mucosal cell layer. This feature is developed. After severe GI hemorrhage, anemia may be developed, that is iron deficiency anemia. Another two pathological conditions can be observed in the ulceration patient, which are pyloric stenosis and perforation. Pyloric stenosis is the situation where any type of obstruction at the pyloric end. I have already described the area of pyloric sphincter. there are two sphincters or two ends at the junction between esophageal and gastric surface, cardiac end, and at the junction between gastric surface and duodenal surface, this is pyloric end. Pyloric stenosis is the problem where constriction of the muscle of the pyloric end is developed. After constriction, the area of this pyloric sphincter is non-functional, becomes non-functional. As a result, emptying of gastric area is delayed, which causes gastritis, gastric ulceration, and acidity. Last condition, perforation. Perforation is the situation where, due to continuous chronic ulceration, gastritis, damage of the mucosal cell, a cavity is formed, and this is because of the necrosis of mucosal layer. Therefore, perforation is the cavity-like condition, cavitation, which is formed due to chronic gastric ulceration for a long period of time. These are the common symptoms and later in stage complications which are formed during ulceration. This video lecture will be continued. In the next video, I will discuss the main problem or pathogenesis of gastric ulceration and what are the treatment and medications for this. Thank you. Best of luck.